Hello, my name is Dr. Rebecca Seagraves, and this is Pregnancy, Birth, and Beyond. And I'm joined here by Dr. Melanie Sutton, and I'm going to actually have you introduce yourself and your background, and we'll get into the topic at hand.
Hello, thank you for having me. I am, as Rebecca said, Dr. Melanie Sutton, and I've been a pelvic health specialist for the last 15 years. My background is in acute care as well as outpatient home health, and I have specialized not only in pelvic health, but also in oncology and lymphedema rehabilitation. And so I have a varied background. I also have spent a lot of time in geriatric and general medical care in the acute care environment. So I have spent the last 15 years working in a hospital-based outpatient rehabilitation clinic, and just 7 months ago opened my own private practice, specializing in clinical care for pelvic health, as well as consultation and coaching for pelvic wellness. So I am an experienced clinician and a new business owner.
And I can agree with that. I really believe that you've been a business owner, honestly, Melanie, if I could just be frank, for longer, but you've been doing it for free. You've been not only a mentor, and it's honestly, it really honestly has reminded me, goodness, how long has it been now? 7 years when you were coaching me, actually 8 years, when you were taking me under your wing and really just working on things like building my resume, working on my interview skills for the residency in women's health that I did, working on confidence, communication. And I said, oh my gosh, I pay people now to do that. And I'm, just kind of floored that really it's taken you this long to kind of, find your way into the business world and just provide direct services. Because I'll be honest with you, Melanie, we've talked about this before. As my CI and mentor, ever since I, graduated, we've talked about that burnout and my up and downs. And we've had these conversations together, and now we actually get to have it, recorded so that people can really see just this transparency of what it means to be a pelvic health specialist, what it means to do this work. But I've been very, very open and honest with you that I've found, some really bumps in the road that has really kept me being a pelvic health therapist and staying in this field. So I want to get a sense from you, like what made you decide to finally say, okay, enough is enough. I don't want, this interference between me and the people who are here to see me. And I want to go out on my own and start my own practice. Like what did it for you?
I felt that there were a lot of barriers to providing care the way that I wanted to provide it. I felt like there was a lot of pressure that was being placed on me, that was getting harder and harder to provide the care in a way that felt good to me. And it was in line with the way that I wanted to provide it, the way that I felt good about, and in a way that wasn't burning me out at both ends. And so having done this for 15 years, I could tell that it was not sustainable for me to continue to practice that way for the rest of my career, and that I needed to make changes if I was going to continue to practice in this field. And so that was the decision that I came to. And so, it's both insurance, pressures from insurance, pressures from corporations, pressures from, from all these other parties that are coming down and trying to dictate how we provide care. And then that is getting coming down on us from all these different directions. And then we're trying to scramble to continue to provide a really high value with less and less resources to do it in. And it becomes increasingly difficult to do. And yet we're trying to function at such high standards within that environment. And it's just not sustainable.
I totally agree. And I don't want, our audience to confuse this talk. We're talking about preventative care. We're talking about raising your income, through the practice of preventative care and not sick care. And I don't want this to come across as we are just anti-health insurance, right? There's a time and a place for health insurance. When my mom had a stroke, and really the battle and the challenges I was dealing with, during that time, I was a student when I was under your wing and mentorship. And it was 3 months before I started PT school that she had this massive stroke. And we're in the hospital, Melanie, I kid you not. And I just, in my 26-year-old, just jittery self, knowing that my mother cannot speak, she can't walk, and yet she had had a history of going into the emergency room when something was wrong. And I had not given her updated insurance information. I had not given her updated Cigna card. So I had no idea until almost 2.5 days later that they were withholding procedures, imaging services, because they felt like, she couldn't pay and she was going to be in a nursing home anyway. So I had no idea that she could have gone to inpatient rehab so much sooner. So I've had this like love-hate relationship with insurance, because I know once that insurance kicked in, boom, she was in inpatient rehab. She was in this beautiful facility that just mimicked the home and the grocery store and the bank. And they had, her getting into and out of a car. And I was just like, wow, it took you guys that long because you were basing your care off of whether or not she was going to be able to afford it, which I get it. Healthcare is a business and an industry. So let's not pretend anymore that we base care on people's finances.
Right.
If we're just clear about that, then that's great. Let me do what I'm doing in terms of providing direct care without you dictating when and where and how they get those services. And then we're good. So I mean, for you to have been in this for 15 years and for me to I was ready to jump ship after 2 years, Melanie, what were you, who were you treating? What were you treating that you were like, oh my gosh, I could do this different. Tell me about that. Tell me about that change.
Yeah. So, and I agree with you. It's not that anything is better or worse in insurance or cash-based. It's not either or that one is better or worse. I mean, it's both and really. I mean, they both have their place. And I am not about pitting one against the other. That's not what this is about. But let's not pretend that insurance doesn't discriminate against patients, either. So, to say that if someone is cash-based, you're discriminating against people who can't pay cash. Well, if you are insurance-based, you're discriminating against people who don't have certain insurances either. So it's the way that it is. It's the way that the systems are. So what I will say is that I have worked in an insurance-based system for 30 years. 15 of it was in pelvic and oncology, but I worked inside a hospital system for the entirety of my career. So it's only been in the last 7 months that I've gone to a cash-based practice. What that has opened up for me is to reach a population of clients who is proactively seeking care outside of that model. So they are looking for people to serve them in a different capacity. They are looking for people to guide them on their health rather than seek their services when they're not. So not only am I able to provide services for people who are, needing them when things aren't going right, but they're looking for people who are wanting to help them before they get to that point. And that's a different shift from what I was doing before. So, one of my favorite client stories, And yes, she sought out the care of a physical therapist, but she sought her out because she wanted to prepare for her birth. And she found out about physical therapy and the role of physical therapy from her yoga instructor. And so she sought out directly to see a PT because she found out about PT from a yoga instructor and thought that that would be a great idea to help her learn about how to prepare to have birth. This is a great success story because I got her in all of the positions and found out what the best one for her was to push before she went and had her baby. This client came back to me after she had her baby when she was having prolapse symptoms. We found out that her prolapse symptoms were more because she was having some guarding in her pelvic floor than it was that she was actually dropping a prolapse and having lack of support issues. Guess what? She came back to see me after baby number 2. This is a lifelong relationship with this client. So this is a different sort of model than what we are used to seeing in a traditional medical model. And so I feel like it's more of it's outside a traditional model of physical therapy and more of it's a shift in the delivery of care and a shift in the relationship that we have as providers with clients. And that's the kind of care that I'm looking to provide. And that's how things can be different. Another example of that is someone that I worked with who was experiencing some sexual difficulties and needed some guidance around it. She didn't have, if you will, impairments. She didn't have physical therapy, things you could find on an evaluation that needed care. She needed some basic education and some strategies to help her, to function better, but not in a truly physical therapy way, more in an education and consultative way.
So Melanie, let me stop you there. You're doing air quotes with physical therapy and impairments. People don't know what that means. Like, I didn't even know before I started this journey on being a physical therapist and then being a pelvic floor specialist, that we actually had to wait until people had a problem to see them if we wanted their insurance to cover our care. And once that set in with me, because even as a student, I didn't even really know, like I was under your mentorship. So all I could say was like, oh my gosh, I have the best CI. She speaks to her patients as if she's educating her family. I would have wanted you to treat my mother. I would want you to treat my sister. I would want to treat my patients the way I saw you treat them. I didn't realize that in that process, you were thinking and thinking and thinking, how do I justify this? Where do I put this on? What do I code this under? What can I say that there is an impairment? Is there really? Because I'm trying to prevent one. And I was just like mind boggled once I really got into it. And I was like on the ground and I was like, oh, wow, you really can't see me for wellness, for preventative care. But yet I was a personal trainer before I got into this. I saw the detriment and the struggle and the challenges my family had to go through when my mom had a stroke, and now we were just trying to pick up the pieces afterwards. You mean to tell me that you can't prevent this if she comes in with her insurance card? So then teach me another way. And that's when it was like a block. We did not learn this. We did not learn how to actually create a business, how to, navigate that system. And then even if we wanted to accept insurance, we didn't learn how to actually do it the right way so that it could actually save people time, save people money, and still provide them with high quality care.
So to that point, I will say that the longer I practiced, the more I felt like I was jumping through hoops trying to fit what I was doing into a physical therapy model, as opposed to more of a coaching, consultative, and education model. Like, it became harder to flip that script because it felt more less like an intervention and more like facilitation and consultation and a guidance. And that was also part of what shifted me in this direction. So, you're seeing that and picking up on that was part of my journey as becoming, I think, shifting more in my role and how I practiced.
Right. I want to invite someone up to the stage who I went to school with. Actually, I got my doctorate of physical therapy with her in Western North Carolina. Now I'm a New Jersey native. And I'll be honest with you, Melanie, it wasn't until I actually did a residency in Durham, North Carolina, where I actually treated people to the extent that I treated them who looked like me. We know Western North Carolina, we know what that demographic was. But then when it came to the pregnancy and postpartum population, I had to wait to see people in the hospital because they didn't know that they had access to a physical therapist or a pelvic health therapist. So when you talk about that woman postpartum that you were doing all those positions with, or pre-pregnancy, think about me. I finally actually got to treat Black and brown women, but I had to treat them where they knew to go, and where they knew to go for their pregnancy or to give birth was in the hospital setting. And so I say that now because I realize if I don't accept insurance, if I don't work in a hospital setting, I do carry that weight of how do I reach the people who look like me, who are at the most risk? How do I broaden myself? So I brought this, I'm going to bring this speaker up because I notice, at least from her website, and we'll learn more about her business and how she's been able to incorporate it. She does accept insurance. She does accept people who are direct care pay. And I couldn't be more happy to bring up my former classmate, Dr. Goforth. All right, Mary, welcome.
Thank you.
So tell us a little bit about your practice.
Yeah, so I'll make a long story short. I started, well, I guess just like right now, I practice in Clyde, North Carolina. I have a business out there, or buildings out there, but I started actually doing mobile PT, mainly because I had a non-compete with my previous employer. And so I was like looking for like, where's outside of a 10-mile radius and where can I go? And
so what does that mean? What does that mean for people who don't know what non-compete is?
Oh, sorry. Okay. So a lot of employers will have, when you sign up, if you may not pay attention, you may see it. I didn't pay attention, but usually somewhere in there, or often I should say, maybe not always, there's a non-compete clause in your contract. So mine was just for a year, and I could not open my own practice for a year within a 10-mile radius of any of their locations. So it was easier for me to just start mobile. I also couldn't like tell my old patients where I was going, but if they found me, that was okay.
And that's because we have 100,000 pelvic health therapists in the country,
Yeah.
right? Like we have so many that we can just roll. Please read your contracts before you work for someone else.
Yeah.
This message was brought to you by Dr. Rebecca Seagrave.
Yes. But it's, I think like a lot of outpatient, I was working at an outpatient practice. It's like fairly standard, but, and I think it was meant to be that ended up where I was, but yeah, Clyde, North Carolina. And that's an interesting demographic. Speaking of demographics, it's a lot of retired people, older people. I'm trying to get in like more with like young soon to be or were just had a baby moms. But it can have its own challenges getting the word out there that you exist. So I do have some moms right now, or women who just had babies. But that took a little bit of time with marketing.
Now, why do you say that? Why? What is the challenge for people to know about you? Is it because when they're searching on Google, or if they're searching through their insurance, whoever's in network with their insurance comes up? Is that one of the reasons that? That's been hard.
Yeah, I don't know, from like all the patients I've had where I'm at now, I don't think any of them have found me by searching through their insurance. They'll ask me, am I in network? But a lot of the times they're referred by their doctor, or I've actually got, I would say 50% or more of my patients because they live nearby. And I'm like the only business building near where they live. And they're like, oh, what is that? Oh, there's physical therapy. Hey, do you take my insurance type of thing? So that's one thing. And yeah, just like time. I mean, I don't know what a lot of business advisors would say, but I think some of them say, give yourself a few years to like really see like how well you're going to be doing. And like, so far for me, it's been about a year, maybe a year and a half since, and then I've only been in the building since like this past winter. So coming up on a year. So it takes time and word of mouth. And honestly, this sounds so silly to say, but just being nice to people and being friendly, they will tell their friends, they will tell their grandma, their mom, their sister. So yeah.
I want to know something from both of you. Okay. So this is just kind of like just an open conversation. And then I'm actually going to try to bring some people who are attending tonight up on stage, just, give their perspective who have been doing this a little bit longer than all of us, right? Because this is really a journey for people to hear the title, see the title, raise your income, and then getting to that point where you can replace your income, right? And I want people who also are the recipients of our care. So this is not going to just providers. I don't want to talk in circles amongst ourselves, but I want people to know that there are ways to save money and to save time that won't disappoint you. And I have to make that clear because as a practicing pelvic health therapist for 7 years, as a practicing pelvic health therapist for 15 years, as a practicing, just physical therapist for 30 years, right? There's a lot of experience even on this stage, but people have to know who are the recipients of our care, that there is sometimes hoop after hoop, time after time that it takes for them to get to us. And by the time they get to us, their scar tissue is healed and is healed poorly. It's radiating to different parts of their body. They are scarred mentally as well as physically because they had to wait so long, trying to figure out if they were crazy or why isn't anyone listening to me? And as a pelvic health therapist, I burnt out before you guys did. So, and that's ironic that I'm bringing us all together to talk about it because I couldn't continue to work in that model of care. I said, this is crazy. This is insanity. Why are we waiting so long for people to come and find us? And so I want to get a sense from you both is that we are on this slow journey of raising our income, but that wasn't our motivating factor. Our motivating factor was providing a care that we were not seeing in our former positions, right? As for working with someone else. So I want to know transparently, Mary, first, what was that for you? What turned on this light to say, there's a different way to do this?
Mm-hmm. As far as just like a traditional like physical therapy setup model, like where you might work type of thing, or
why didn't you go out and do like mobile therapy first? Like what was that? What was your motivation for that? That's a hard transition. People are coming to you and then you're going to get in your car, your table's in the trunk.
Yeah,
you're bringing your Swiss fault. Like what caused you to go that route first?
I'll be honest. I mean, part of it was just I was trying to find a good place to practice, number one. And, but I didn't want to, be without an income, and I still wanted to be able to help people. And initially, although I do take insurance now, initially I was just cash-based then. I'm like, I'm not playing the insurance game. Then I kind of started to have like a moral dilemma, like, but I can't treat people that have Medicare. So maybe I will just Medicare, and kind of went from there. But, yeah, like, I guess, I don't know if this is exactly what you're looking for, but one thing with my previous work setup, I got burnt out on both. I wanted to give my patients the best care, like always one-on-one for sure. Not having to like work on one and the next one's coming in, oh my gosh, what am I doing type of thing. But also myself, maybe selfishly, I was like, had later treatment hours, and then I had to do notes that I wasn't getting paid to do while I was there. I was like, okay, well, if I'm burnout, I can't give good patient care. So that was
Yes.
one big.
And please speak to that, Melanie. I really want to understand, how in the world do we care for all of these people and put our self-care on the back burner? Like what is the burnout rate? Like how many years now?
Well, I don't know. I want
For
to say
physical
it's five,
therapists.
I want to say it's 5 to 7 years for physical therapists. I don't know what it is for pelvic PTs, but I do remember some of the very experienced therapists in our field that taught some of my courses said that the reason they were still in it after 10, 20, 30 years is because they had limited hours. They were not working full time. And those were some of the greats that were saying that. So I took that to heart, and I haven't worked full time in years. So that is part of why I have lasted this long, is that I have worked no more than 30 hours a week but I've also been the mom of 2 kids. So I've worked 60 hours a week. It just hasn't all been in the clinic.
Right.
So that's part of what has been difficult for me was getting kids to school, then worried about being to work on time, getting in trouble if there's a traffic accident, worried about getting in trouble if I'm late to getting to work, getting evals slammed at the end of the day, and then worried about getting to my kids on time, kids getting sick, and then I need to be at home with them, but I can't because I have to be at work. So that work-life balance did not go well. Needing to stay late to document, but then I'm gonna get, dinged if I can't get to my kids on time. Then my kids don't get the best of me because I'm spent from everything I give at work. That work-life balance was not going well. It did not feel good to me at work when people wait 3-4 months to get in with me, and then I can't get them back in for their follow-up visit for another 2-3 months because I have no control over my schedule. That does not feel like good care for me. So I'm busting my ass, frankly, to give them everything I have on that first visit, knowing they can't get back in for 2 months. They're mad because they waited 3 months to get in to see me, and mad because they can't get in back to see me for another 2. And nobody feels good about that. So it doesn't feel like good care. And that led a lot to me feeling like I can't do this anymore. So I'm rambling, and I'm not sure if I answered your question.
No, you're not rambling. No, you are speaking the truth. You're speaking the truth that every person who receives our care has to realize about pelvic health, that this it's become customary in our
And I
systems
think
of care.
And there's more and more of a push to be shortening sessions and passing off care. And
Oh, you have no idea.
What
30
can you do
minutes.
less of, and who can you delegate more
Yes.
to, and yada yada yada. And so I feel like it's becoming harder and harder to feel good about what it is that you're doing. And so the burnout is real.
Mhm.
And to your point about people getting to us earlier,
Mhm.
and that dripping of people getting to us later, there's always things that we can do when they get to us, however they get to us. And yes, we would love for them to get to us sooner. And we're working on that. You're working on that. We're all working on that. When they do get to us, though, we want to be able to give them top-notch care. And when we can't, and those limitations are outside of our control, then I feel like there does get to be a point where there's a tipping point and something has to change.
I want to bring this full circle. I'm going to bring up 2 guests to really give even more perspective about this. We talked about this last night when we were talking about our role in prioritizing mental health, because what I'm hearing you both say, Mary and Melanie, is that one, it's unfair for us to expect that we can operate at such a high demand that our healthcare expects, whether it's 30-minute visits or 45-minute visits, when we are also dealing with people's emotions of having to wait to see us, with having to wait without answers. And then once we are able to finally have that time with them, they ask us, well, why didn't anyone tell me about you sooner? Now it's like a realization, but then also this anger and all these emotions. And it's like you went through highs and lows with this person. They loved you and now they just hate everything. But you know, I mean, so it's almost like I want to provide that perspective because we're talking to people through this recording on both sides of the issue. And we're not anti-insurance. Obviously, there are those of us on the ground like Mary, who's like, I want to be in network because I realize that cash pay system is not attainable for everyone. So this is not an if or this is an and. This is a combination of people that, well, if you can't see this person, can we do this differently and provide this or provide this? We have to work together as a team if we're going to change this system. So I'm going to call on someone who was a speaker at our event in prioritizing maternal mental health using OT and PT services. So Dr. Dionne Middlebrooks, is here with us. And I really want you, if you can, talk about your practice, why you decided to start providing direct care services, because from what I understood, you don't accept insurance. And I have to highlight you, Dr. Middlebrooks, because, and I'm going to say it, I'm very transparent, you all know me, is that I feel like there's almost like an expectation that if you are a woman of color and you're a physical therapist of color, well, why would you not be accepting Medicaid? Don't most of your people have Medicaid? How are you getting to your community? I've had those moments where it's like, well, man, am I doing a disservice? And then I have to remind myself, oh no, y'all are not going to trap me with that. So I need to hear your perspective, please, because I can get on my soapbox all night about this.
Well, yes, you already know I probably have a lot to say about it. But yes, I do have a mobile practice, and everything that everyone else already said about being burned out and being tired, I completely relate to that and understand and empathize with each one of you. I do not accept insurance. I do not advertise that I'm a non-participating provider for Medicare. That means that I'm not participating with them. I do not have to accept assignment. However, if an individual, if I'm noticing that they're having a hard time finding anyone, I pretty much can accept their Medicare benefits and charge at a slightly different rate than what Medicare allows. But that is the only thing, and my schedule is not filled with that. Because there are other clinics who can service that individual. They just have to be willing to drive, and I'm a mobile therapist, so I do take the time out of my day to add in the commute as well to go to them. Now, let me address the Medicaid issue. One, it's extremely frustrating when people just automatically assume that based upon how someone looks, how someone dresses, that they can't afford. This hits close to home because unfortunately, with my most recent birth, my last child, the OB office treated me as if I was nothing. They pretty much made it seem as if I could not afford their services. And then when they started looking at my name, they were, as you can see, my first name, my last name were pretty unique. They were like, wait a second, your name sounds familiar. And I started laughing. I said, why does it? And they said, oh, we refer to you. You do. And you'll continue to refer to me because I'm the only individual in this area, but I will not be coming to you. So people need to realize that they have a choice in who they go to see. Even if you are a Medicaid patient, yes, your options may be a bit more limited, but even if you're seeing someone within a hospital system, you can easily say, I want a different provider. That is your right as a patient, and we need to make sure our patients realize that. I even tell my own patients, if you're not comfortable with me, let me help you find someone you're going to be comfortable with. Because the ultimate goal is for you to get the care that you need. And if I'm not it, we need to find someone who is. And that's across the board. So like I said, yes, Medicaid can be a bit more limiting because they typically have to go through the hospital systems. But even within that system, we need to make sure they realize you can say, no, I want a different doctor. No, I need a different provider. That way they know that they have that right and that benefit. But even then, I'm still able to reach individuals who are still a part of underserved communities with various community outreach activities. For instance, I'm currently planning one right now, and that way Why? Because not everyone's going to be able to come and see me for paid services. Not everyone's going to be able to go, and even with their insurance, most times a lot of people can't afford the copays. Because let's be honest, you're paying a copay, and let's say oh my goodness, especially certain insurances like in Georgia, like with Ambetter, you're limited to a certain number of visits per year that you split up between the disciplines. And then in addition to that, you have a copay that they usually are not aware of, and they can be significantly high. And you're seeing your therapist for 20 minutes and you spend another 40 minutes working with the tech or on your own trying to guess what you're doing. So the purpose of the community events, I really think that we all should just take a push and kind of explore that option as well. Yes, you're giving up your time. Yes, it's pro bono. Do you have an hour to do, every 3 or 4 months, just to put the word out there? Hey, this is what you can do. What questions do you have for me? I can answer your questions to an extent, of course, because we're not able to provide certain medical and or health advice unless someone is our actual patient. However, we're able to give the basic guidance as to, here's what you're telling me. These are different options and services and different things you should consider. Take this information that I've just now given you and utilize these resources, speak with your own healthcare team, and hopefully that can help you figure out a plan that you have moving forward. And people will be open to that. Even if you're saying, I can't treat you, let me find and help, and that way you can at least get the services that you need. So, but unfortunately, as healthcare providers, we are all guilty at some point in time as far as stereotyping someone. So we really need to honestly check ourselves. We need to make sure that we are aware that the person sitting in front of us is just that. They're a person. They have feelings. They have a family. They have individuals that love and care for them. And we need to make sure they feel loved and cared for in our presence as well.
Dionne, you are hitting on so many things. I'm from New Jersey. Right. So everyone expects me to talk that fast, but wait a second, you have hit on some things that I need to just pump the brakes. First of all, patient advocacy, patient informed consent. When you have made the decision for that person that, yeah, we're not going to provide these direct care services to you, even though we know it will shorten your time of recovery after, say, a C-section or a hysterectomy, even though we know you can get returned back to work, you can be your whole self for your child, you can be your whole self for your community. If you are that beacon in your community, we know that these services can do these things after trial after trial after trial, like Mary saw in her system of, people having to wait a long time and having that mental distress and having that anxiety over that chronic pain or issues that they were having. She knew she could circumvent that by going directly to them in her mobile practice, and which Dr. Sutton does too. So we know that our services shorten their recovery time, even raise our clients' income, right? Because they're able to provide for their family now, but yet we have profiled them and said, yeah, you're probably not going to pay me. Yeah, I don't want to offer my patient, if I'm an OB, GYN, or if I'm the doctor, or if I'm the surgeon, I don't want to offer my patient that option because they're probably not going to pay. They want an insurance option. So we are profiling people left and right. We're not even providing them with the information to make that decision themselves. So we as a system have already decided, well, if you don't come with me with a plan of how this is going to be paid for, I'm not even going to provide people with that option. What are we doing there? We're taking away their informed consent, right?
We're taking away the informed consent, and then also we're taking away their dignity. And when you take away you strip someone's dignity away from them, that is so deflating. So we really need, so informed consent, don't get me wrong, it's extremely important. We do need that, but someone's dignity, that defines who they are. And you don't want to take that away from someone. So like I said, we are all guilty of it. I'm raising my hand to that as well, because I've had to check myself with certain things as far as even with certain clients. It's like, okay, you know what, can I work out something for them where, yes, even if it is a shortened session, but they're able to afford this, or am I able to offer this particular opportunity for them instead? So it's caused me to honestly revamp my own system, so that way I can try to serve more people and also make sure that I'm not that I'm not overextending myself, but I'm also not limiting information that they're receiving as well. So it's caused me to have to revamp my own system. But when we do that, we're taking away their dignity.
Okay, so let's recap here. Dr. Sutton, how long have you been in your own practice? Like where you have now decided, okay, wow, I've raised my income to the level of where I was making it before, working for this institution that was limiting me. How long have you been in business for yourself?
I opened during the pandemic,
Mhm.
but I will say that I didn't really go all in.
You
I don't-
sound like you're apologizing. I want to know, how long have you been in business?
7 months for real.
7 months. Okay, that's not an apology. This is actually hope. This is giving me hope.
7 months.
Okay. Dr. Mary, how long have you been in business now for yourself?
About a year and a half.
Okay. And Dr. Dionne, how long have you been in business?
I'm going to tell you, I've been completely independent now for my youngest is 4 months. So for 1 month, completely independent.
1 month.
Before
I love
then,
it.
I had a side hustle, but
Yeah,
it's
you
full-time
still
now.
sound apologetic. I'm gonna call you out. I mean, I don't even understand. Like, what? You're in business now. You're
That was-
providing direct care now. Can we just celebrate? And I could, if I put the little emoji, I guess my audience can't see it, but for the people who are in this room, I know
That
you
was
see
me
my,
with the
I know
side
you see my
hustle.
streamer.
I got you.
Thank you. I'm going to call someone down now who's been doing this work for longer than probably all of us put together. Yeah, I also, like Melanie, I started after the pandemic once I was working in that hospital system, and I was being asked to come to people's homes at that time. Even during COVID, they wanted me in their home. They wanted to take me home and have that care continued after an unexpected C-section in the middle of the pandemic. I knew I had to change. And so I'm going to bring someone down who's been in this line of work. I want to know your motivation. I want to know the inspiration that keeps you going, because pelvic health therapy, we've already heard for almost 45 minutes. Wow, just in and of itself, it can be a burnout, seeing the things that we see to the people that has happened to for way too long. So if you will all mind or just forgive me, it's just going to be a moment till I get her on stage. Beautiful. Dr. Catherine Sylvester, welcome. Now, you have been on each episode, so anyone who has not been following, please make sure that you see the first event and the second event. We've had Dr. Sylvester on, just a wealth of experience. Welcome. Thank you so much for your time.
Thank you for having me. Hey, everybody.
Excellent.
Yeah,
Tell us a
so
little bit about your practice.
So I'll tell y'all what I think is important about the practice. So I bill Medicare when I have patients who have no cap on the amount of times that I can see them. And so I'm really particular about those people. And if they ask me to do them a favor. So I typically at one time will be billing 2 patients that have Medicare, because I have to take into account the time that I do the billing. And then so that is for mainly people who have strokes. So they may have had a stroke, they had therapists that completely ignored the side that got affected. And so right now I'm working with a triathlete, and we are getting back to doing everything that she wants to do. But for 2 years, she had therapy and they did not touch her left side. And so I know. And so people call me because when I was in the hospital, neuro was my thing. So I had a neuro unit built in the hospital, because when I got there, they were only seeing people for 10 to 15 minutes, regardless of diagnosis. And so I got reported for seeing patients for a long time. But I ended up writing up a proposal, got approved for $100,000. They broke down the walls between 2 rooms because we had an ortho gym and they were joint certified. So I said, well, we're also stroke certified. So why don't we have a neuro gym? And so along with the speech therapist and occupational therapy assistant, we built the gym and ordered all the equipment, and we ended up spending $60,000. And all of the patients were seen for 30 minutes of PT, 30 minutes of OT, 30 minutes of speech. And so while I was in every day, and so when people said, oh, we don't know if they're ready to go to rehab, we're like, actually they are, they're already tolerating their hour and a half. So it really was good for us to get people in where they needed to go. So anyway, taking that mentality to the home, I felt like patients needed to be seen longer. And I would not want my appointments to be stacked so that I didn't have to rush out of their homes. And so I go into their homes, but I also go where they are. So if there are women after, they have their baby and they box, I'm in the boxing ring with them. If they are in CrossFit or Orange Theory, then I go where they are. And so those patients, my public health patients, they are typically cash-based. And I also do scar massage. So I have my 3 programs from scars to beauty marks, where I go and I travel everywhere to do scars. I took a course up in New York a little bit into my career, and really I was wondering, because I was running into women who were having really bad issues. Most of them had C-sections. And I was like, I bet it has something to do with that scar. I need more tools. And so took some courses, had better tools, and it was great. And so my son was the reason I left, honestly. I felt just like some of you, if I worked full time and I knew my son was at home, I would be sad. So I went to my boss and I said, hey, I need to go part-time. And she was like, we don't have a part-time position where you can still have benefits. So I reminded her that when she hired me, she didn't have a full-time position either, but she created one. So she created one for me. And I changed my schedule to where I worked 8 to 12. I was on break with him from 12 to 1:30. And breastfeeding. And then I got off of work and breastfed him afterwards. It was wonderful to have that flexibility and just realized I wanted more time with him. So that took me part-time, and then COVID made me full-time. I'm full-time working for myself. My child, I had to teach him from home, and you know how it was. They were in school one day, not in school the next day. And so I was like, you know what? I have been working. I was already making what I was making on my job with just having 12 visits a month. So I sat down and I was like, what do I need to make what I'm making part-time on my job? And then what was the bare minimum that I need to make to cover the household expenses that I am responsible for? And I got it down to 12 patients a month. And I was like, I can do this. Why have I been working 80 hours a week, right? For when I could just do the 12 visits. And so that's what happened last September. And it's been a year and it's been wonderful. And now the other business that I have is called Operation Mist, where we remotely monitor women with smart devices, their health metrics while they're pregnant and postpartum, make sure they don't run into complications. That business right now is not, I'm basically breaking even with that. So I added 4 additional in-person visits during the month so that I could keep Operation Mist afloat while I'm scaling it. And it's been wonderful. And a lot of what I'm doing, just so that y'all, just think about all the different ways that you can make money. So when I initially started my company, I knew that I couldn't serve people who couldn't afford $200 a visit, right? And so I decided to take 10% of everything that I earned and put it towards people who couldn't afford it. So I always took 10%, and so then I could take people for free. And so in the same way with Operation Mist, there are people who can afford to pay us $50 a month, $100 a month, but there are people who cannot. So I have written grants between last September and this one. So when I say I break even, that is not using any grant money, but we have gotten a $40,000 grant, a $15,000 pitch competition. So we pitched for money, just won a $5,000 grant from Healthy Moms, Healthy Babies, and am currently with they're called the 5'9" Club. So trying to make sure that the babies are at least 5 pounds, 9 ounces. They are writing for a $13,000 grant so that they can pay us to monitor their high-risk moms. And so there is money out there, and I just feel like I can make money, but I can also get free money and serve the patient population or the people that I think really need to be served.
I'm curious. So do you accept Medicaid in your practice?
So no, I'll just say no. I do not.
Just gonna leave it at that.
Yeah. Well, I have a little girl right now. To be honest with you, my heart can't take it. So then I would end up going to see patients after, like, they are not given enough coverage for physical therapy. And when so if it's 8 units a month, I get to see the little sweet little girl who has spina bifida once every other week. So I end up staying with her for 2 hours a visit, only billing for 1, so that I can go back and see her the next week and do the same thing. So I'm doing all of this, and it's very frustrating because I still feel like the time that I'm spending with her is not enough. And so mentally it is, emotionally it is. She loves to see me because I have someone right now, but honestly, I hate crying. It pulls at my heartstrings every time I go. And I'm just like, I think I probably just shouldn't, because they don't reimburse well enough. So I spend more time at the Capitol fighting for reimbursement that, and more visits, even if the reimbursement is not great, but someone paying for that. Like there are funds out there. So instead of us fighting for reimbursement, we can go to places that just have money for, let's say, people who are disabled. Then I can go and get funds from there. And just, even if that just covers gas money from here to the 40-minute drive that I have to go see this little girl every other week. And so, yeah, I don't think my heart can take it.
So if I can just kind of recap, and this is even for everyone on the panel, is that if I'm hearing you correctly, okay, based on Dr. Sylvester's like just amazing expertise, experience in this area, if we are able to find that number that we all individually need, we all know what that is. As clinicians, we know what we need to sustain ourselves, to get the reimbursement back into what we put for our education and our certifications and specializations. If we were to just determine what that number is and then backtrack from what Dr. Sylvester just described, we have the time to learn to advocate for those who don't to have the time to visit people and spend more time with them, to have the time to learn how to write grants of $40,000 to $100,000. Do you hear that range? To learn how to build systems within systems that were not designed to serve people the way they were meant to be served. She just described building program after program to where she got to the point where she outgrew her system and had to work for herself. And so if I'm hearing you correctly, by focusing on that high quality, on that prevention, and on what we need to sustain ourselves, that should have been the first thing, right? Oxygen first for yourself before you put on the mask for someone else. If we actually start there and work our way back, you're telling me I have more time with people and I can provide better care. Are we all in agreement with that? Does that make sense? Am I on mute? Can I hear some feedback? I know the heads are nodding, but I want some feedback.
Yes.
Yes, amen. Dr. Sylvester, one more question, and then I'm going to close out with all of you. But one more question. I had someone from the audience ask, is Operation Mist, where you're monitoring mothers from preconception to up to 6 months postpartum with a wearable to 1 year, 12 months postpartum to 1 year postpartum through a wearable device, is that a nonprofit?
It is not. It's for profit. And a lot of people think, well, you only get money if you're a nonprofit, but you don't. There are plenty of people. And honestly, there have been some people who have said, I know you're a for-profit, but we still want you to apply for this grant. Another way that you can do this is to connect with a nonprofit who cares about your cause. So the National Association of Black Physical Therapists has a maternal health arm, right? And so if there are grants that we cannot apply for, then they apply for them, and then they, take whatever they would normally take, and then they put it towards the moms. And honestly, just because of who they are, I say they take what they're supposed to take. They take nothing and they give it all to the moms, but that's how it would work if you wanted to go through a nonprofit. I haven't had to do that, but people have donated to us and I wanted to be able to give them the receipt that you get.
Tax deduction.
Yeah, and so the NABPT took it on our behalf and gave that to them because they gave it and didn't realize that we were not a nonprofit. So
that's amazing. So they almost sponsored your the funding that people gave. They took that on and they're giving that tax deduction on your behalf.
Yeah.
The partnerships that you've made are incredible. I want us to end as a panel, each one of us, take just 15-30 seconds, just bring it all together, because I really want to speak also from the perspective, if any of you can, of what a recipient of our care feels and how it impacts even their financial health as well, for not having to wait the length of time that our standard model of care will have them wait, or not have to use their insurance to the max to have to reach that deductible and then be able to see us. I want you to describe our role, your values in raising our income through preventative care, not sick care, if you can. And I'll end with this with me. I didn't, necessarily talk about what I do, but I feel like very much like Dr. Sylvester, what brought me into this work is not necessarily what's sustaining me anymore. I was brought into this work by seeing the care that I could have provided. And now I'm teaching acute care physical therapists and home health physical therapists and occupational therapists how to provide that care even sooner. So I'm still working within those models where people have their insurance, they're already in the hospital, they've given birth, they had a hysterectomy, whatever it is. So why not actually train our providers that are already there to just treat them like they would any other person that walks through those hospital doors? We have a system that is disparaging against women, against pelvic surgeries that are performed on women. Cesarean section is the most common surgery performed in the United States. And so if we don't have systems in place that prioritize their function and their recovery and their ability to return to work and provide for their families, then what do we have? We have a sick care system that's going to be waiting for those individuals to need us later. And I don't wait for research to hit our evidence-based journals before I act. So I want to hear from you, if you can all go around and just say one thing that you want the audience to leave here with about your mission, about your personal values, about what's making the care you provide different. Dr. Sutton.
I knew I was going to have to go first. That's a tough act to follow. So I want each person that comes to see me to be really glad they got to me when they did, even if they wish they got to me sooner. And to feel like every moment they spend with me is valuable, and that it doesn't take very long for them to get where they want to be, and that it was worth their time and their money, and that they are better than when they came, both physically and emotionally and mentally, and that they're in a better space to live the life they want to live. And I will know that my goal has been fulfilled. And I want to also help other colleagues and other therapists to get to that space where they feel confident and comfortable in delivering that level of care as well.
Beautifully said. Thank you. Dr. Mary.
Oh, all of y'all are a tough act to follow. I guess I would just, not to copy, but yeah, I mean, absolutely. I want big picture people to be happy that they came. I think one of my greatest treasures as a pelvic health therapist is just comments like, wow, like I didn't even know pelvic health was a thing. I'm sure all y'all have heard that from patients like, oh my gosh. One lady years ago, she was like, I have had painful sex for 10 years. I had no idea. And I almost started crying. I was like, oh my gosh, that's awful. But yeah, just to be that little light in someone's eyes. And I guess one little different tidbit, it's so nice working for yourself to not feel that pressure of, I don't want to say that I would when you wrap up your session and you're like, okay, I recommend this many visits a week for this duration. There was always that pressure, like, you better get them in twice a week, minimal once, I'm just like, but what if they don't need it? What if they can't afford it, And so now I'm just like, I'm going to lay out like 4 options for you. If you want to get better faster, come and see me twice a week based off what you got going on for a month. Let's see where we're at and go from there. If your schedule doesn't allow that, or you can't do that financially, that's okay. It may take us longer. We can do once a week. We can do every other week, do your homework, that type of thing. Like that is so satisfying to not feel that pressure and just give them all their options type of thing. So I guess that's my one little different thing to say.
I love it. Love it. Love it. Thank you. Thank you. Thank you. Dr. Middlebrooks.
So the biggest things I want for people to see, to recognize when they come to see me is that I want them to be there and to realize that they should feel empowered. So that's something I want for them to leave with. I want you to leave empowered. And then I also want for you to see my heart. I want you to realize that because I am human, that there's a chance we may not agree on everything. I want you to realize that regardless, I support you, I see you where you are, and I want you to see my heart. And I believe the best way for to do that, especially as we all are leaders in our community, is to just serve. So I want them to see that I'm working to serve them. And I want them to see my heart.
Love it, love it, love it. Dr. Sylvester.
I want them to leave with more resources and connections. So I make sure that, just how they just found me, that they don't have to regret not finding another professional or being connected with another resource or organization that could help and support them. So that's what I want, people to have a lot of people loving on them during their journey.
You all are providing people with information, you're educating them, you're providing them with care that they often don't expect. White coat syndrome is a real thing, right? And you're providing them with one-on-one time, and your time is valuable. And I cannot thank you all enough for spending it with us tonight. Thank you so much. I will leave your information for people to connect with you. I'll tell you right now, I apologize for the emails that you might be inundated with, but what you are doing is groundbreaking work. And whether you are 4 months, 1 month, 2 years in, you are doing something that we absolutely are going to build on and provide a better future for people and more hope. So thank you.